Hello, everyone. Welcome to 4sight Health's first ever virtual health policy debate. Our topic today is Medicare for All. My name is Dave Burda. I'm the news editor at 4sight Health, and I'll be the moderator for today's discussion. Arguing in favor of Medicare for All is Gerald Friedman. Gerry is a professor of economics at the University of Massachusetts in Amherst and author of the book, The Case for Medicare for All. Pretty self explanatory. Gerry is a proponent of a single payer healthcare system, and he supported then presidential candidate Bernie Sanders' healthcare reform plan in 2016. Arguing against Medicare for All is David Johnson, founder and CEO of 4sight Health. Dave is a former healthcare investment banker turned healthcare disruptor and author of the books Market versus Medicine and The Consumer Revolution in Healthcare. Dave is a proponent of a multi payer healthcare system, and he supports market driven healthcare reforms to make the system work better for patients. Welcome, Dave, and welcome, Gerry.
Thanks, Dave.
Thank you.
All right, before we begin, I'd like to throw a few cards on the table. First, both Gerry and Dave believe that the current healthcare system is too fragmented, too costly, and too cruel. Both believe that the system needs a major overhaul. Second, they also agree the goals of reform, affordable and accessible healthcare for all Americans that doesn't break the. But Gerry and Dave disagree on the best route to achieve those goals. Their debate will center on how best to re-engineer the business of healthcare to maximize healthcare's overall benefit to individuals, communities, and American society. With that set up, here's how today's debate is going to roll. I'm going to ask each of you to make a short opening statement of no more than 2 minutes, during which you'll share your definition of Medicare for All. Then we'll break the debate into three subtopics: access, cost, and quality, and ask each of you to explain how your position drives improvements in each of those three areas. For each of those three subtopics, we'll alternate positions in rebuttals, 3 minutes for each position and 2 minutes for each rebuttal. Basically, you'll each have a total of 5 minutes to make your case in each of those three areas. Then, after we go 3 rounds, we'll ask each of you for a short closing statement. A lot of rules there. All right. And I've got a timer. All right.
It's good to be king, Dave. It's good to be king.
All right. Are you guys ready?
Yep.
Okay, here goes. Gerry, let's hear your opening statement on Medicare for All.
Okay, thank you. And thank you for arranging this, David. Our healthcare crisis is one of rising costs and quality, where we're not getting quality healthcare for our money. And the solution is to move away from a system of for profit, market driven medicine to a publicly funded single system covering everybody under one umbrella. The problem is not only that we spend twice as much per capita per person on healthcare as the average for affluent countries, but that we're not getting quality in return. Our life expectancy is over 4 years less than countries like Japan and Spain or Switzerland, even though we spend 50% more than they do over in Switzerland, twice as much as Japan, and 4 times as much as Spain. Furthermore, we're doing worse over time in both dimensions: rising costs and declining relative life expectancy. Back in 1970, our life expectancy was about the average for the Organization of Economic Cooperation and Development, and we spent a little more than the average. Now, we're years below the average in life expectancy, but spending, as I said, 50% more. If you want a single number that tells you how poorly we're doing, consider the relationship between healthcare spending and life expectancy. For other countries, additional years of life expectancy over the last 50 years have been associated with increases in spending of $300 to $400 per year per person. The United States, we've purchased additional years at $1,400 per year in spending per person. This means that to gain the average life expectancy of the rest of the OECD, we would have to spend another $5,000 per person, on top of the $10,000 we're already spending. To equal the average life expectancy of the OECD, we'd have to spend 3 times as much as the average. This means that to equal life expectancy in the rest of the OECD, we would have to spend 3 times the average for the OECD, and the gap is growing.
Got it.
Thank
Thank you. Thank you, Gerry. Dave, let's hear your opening statement on Medicare for All.
Well, you're going to see that Gerry and I share an equivalent diagnosis of what's ailing American healthcare. So when I give speeches on healthcare reform, I often ask the audience to answer 3 yes or no questions. The first is the US spends 18% of its GDP on healthcare. The next big country with the next highest percentage is France at 11%. And so I ask the audience, how many believe we need to spend more than 18% of our economy to give great healthcare to everyone in the country? Nobody ever raises their hand. The second question is the US allocates 90% of its healthcare expenditures to treating chronic disease. How many believe we're winning the war against chronic disease? Nobody ever raises their hand. And then finally, I ask the audience on a relative basis, how many believe we should shift resources out of specialty and acute care into primary care, behavioral health services, chronic disease management, and health promotion? Everybody raises their hand. So what does this short exercise tell us? First, healthcare doesn't have a funding issue. We spend more than enough money. Healthcare does have a distribution issue. We don't spend the money on the right things. Secondly, the system isn't addressing its greatest challenge, which is exploding chronic disease, and a big part of the reason for the life expectancy differences that Gerry outlined. And finally, the system needs major restructuring. So it's not a question of what we need to do, it's a question of how to get it done. So my biggest problem with Medicare for All is that it leaves the current delivery system largely intact with its maldistribution of facilities and practitioners, its fragmentation, its underinvestment in chronic disease management and behavioral health services. In my opinion, we need 3 things to revolutionize American healthcare: empowered buyers, liberated data, and pro-market as opposed to pro-business regulation. With those forces acting in unison, we can unleash the American innovation engine, not only to deliver universal health insurance coverage, but also to improve health status, lower healthcare costs, and enhance life quality, as Gerry described. Imagine if the US could spend less as a percentage of its GDP. That would increase or unleash enormous resources to pay people more money, invest in more productive industries, and fund vital public needs. Now, that's the kind of healthcare reform I can get excited about.
Great. Thanks, Dave. And it's very clear my timer is going to get a good workout today. So excellent. All right, let's start the debate. Gerry, as our guest, you get to go first. Tell us how Medicare for All affects access.
Okay. Going back to relatively short life expectancy for residents of the United States, this is directly associated with lack of access. And that comes from reliance on for-profit medicine and for-profit health insurance. Let's be clear, you can only sell something if you're ready to deny it to some people. That's the nature of private property and the exchange of private property. You can only have a negotiating position if you're ready to walk away. Now, in the United States, that means that healthcare can be sold to people only if we're leaving some people out. We're leaving 10% of the population out of the health insurance industry. They don't have health insurance. And 22% of the population reports that the insurance that they buy does not give them access to healthcare. These are people unable to access healthcare because they cannot afford deductibles and copays. This is shown. This matters. Inability to access healthcare is directly associated with higher mortality and shorter life expectancy. This shows up in comparison of states such as Massachusetts, New York, or Oregon with high rates of health insurance versus Mississippi, Alabama, Texas. The range in life expectancy between states, between those with the easiest access and the worst, is 3 years or more. If you look at back in 2012, the Robert Wood Johnson Foundation did a survey of counties. If you plot ability to afford to see a doctor against life expectancy, against average mortality, age adjusted, You get an upward sloping line reflecting that access to healthcare is associated with higher, lack of access associated with higher mortality. The regression has a R squared of over 0.3, which in fancy econometric terms means it's a good regression. And about a quarter of mortality in the United States is explained by the high rate of population who cannot afford to see a doctor. People who cannot afford to see a doctor die. And that's a big part of why our life expectancy is low, because we cut out so many people from access to healthcare because we make it something you have to buy. Thank you.
Got it. All right. Thank you very much, Gerry. Dave, now you tell us how Medicare for All affects access.
Well, I believe Medicare for All would create universal health insurance coverage. That's a worthwhile goal and should be a part of any healthcare reform efforts. The US is a rich country. No American should receive or should avoid receiving vital care because of an inability to pay or worry that medical bills could push them into bankruptcy. Having universal health insurance is an integral component of enlightened healthcare reform, but it's not an end in and of itself. Having Medicare for All does not guarantee access to appropriate care at the right time. For example, there is plenty of money in Medicare today to amputate a diabetic foot, but little money to treat or prevent the diabetes in the first place that would make the amputation unnecessary. The root causes of this profound mismatch between services offered and services needed are Medicare's adherence to fee-for-service payment and the complex formularies it uses to determine reimbursement for specific procedures. A typical Medicare payment incorporates up to 3 diagnostic codes: primary, secondary, and tertiary, as well as potential adjustments for labor and non-labor costs, regional costs of living, disproportionate share costs, medical education, and outlier cases. In response to these complex payment formularies, providers employ armies of coders and revenue cycle consultants to submit and process bills in order to optimize treatment revenues. No wonder hospital bills are so complicated, right? So to state the obvious, healthcare is a big business that generates its revenues through claim submissions. In his book, Healthcare Beyond Reform, Joe Flower identifies the 2 iron rules of healthcare economics. Providers do what the system pays them to do. And secondly, providers do exactly what the system pays them to do. So what does Medicare pay and not pay for? It pays for way too much acute care and not enough primary care. It funds excessive end-of-life care, but inadequately funds mental health services. It supports too many surgery centers and not enough clinics, and so on and so on. Compounding the problem is a prohibition against Medicare's involvement in medical decision-making. As long as a physician deems a treatment appropriate, a ridiculously loose standard, Medicare has to pay for it. But Medicare isn't stupid. They use the complex payment formularies in part to control variation in physician prescribing behaviors. The disastrous result is too much of the wrong care and not enough of the right care. This is the principal cause of declining US life expectancy in 3 of the last 4 years, along with the lack of access that Gerry described. In many ways, and despite advances in medical care, America is sicker today than it's ever been. More of the same Medicare will yield more of the same decline in health status. Not getting appropriate care at the right time is the very definition of inadequate healthcare access. Medicare for All won't fix that. The only way out of this Hobbesian version of healthcare delivery is to get rid of fee-for-service payment and fee-for-service medicine. Pay for outcomes and better health, not more fragmented treatments in sicker populations. When it comes to access, Americans won't get the healthcare they want and need until America changes the way we pay for healthcare services.
Great. Thank you, Dave. Gerry, any rebuttal or reaction to Dave's remarks on access?
Oh, David and I, as pointed out, agree on a great deal. But first of all, the problem isn't Medicare and Medicare's rules. The problem is a fragmented health insurance system that includes Medicare. But most of the administrative costs in doctors' offices and provider offices, costs that come to maybe 10% of total health expenditures, is for processing private health insurance. Now, getting appropriate care, yeah, that's really important. What would give somebody an incentive to provide appropriate care? An insurance company that can't get rid of people, that's going to have to be dealing with people and the long term health consequences and the long term expenses that those people will provide. That's not a private health insurance system. The best way to increase your profits as a private health insurer is to drive out, they call it lemon dropping, drive out the expensive people. If somebody has a chronic disease, find a way to get rid of them. Don't give them good care. That's going to attract more people with chronic diseases. A public insurance system that has to cover everybody, that's going to be stuck with the consequences of inadequate care, is the way, the first step. It's not the whole thing, but it's the first step to providing appropriate care. After that, we've got to deal with making it work, but at least the incentives are there. The incentive for a public insurance system would be to keep you healthy so that you don't become a burden going forward. Give you insulin so that they don't have to amputate your foot. Thank you.
Added. Dave, any rebuttal to Gerry's remarks on access?
Well, I agree that if the US government owned 100% of the risk, it would have an incentive to try to identify disease earlier, treat it proactively. It would be up against a monumental healthcare industrial complex that's wedded to fragmentation, high cost delivery, and so on. So the question isn't would the incentive be there, but the government, which to this point has been incredibly pliable to industry interests, I think would resist efforts to take us in the direction or beneficial full risk policies. Now, I happen to agree that there should be no lemon dropping and that, pluralistic insurance delivery, vertically integrated companies should own the healthcare risk for prolonged periods of time. Individuals should still have the ability to choose their networks, but they should be someone should own that healthcare risk. I mean, I'll tell a story of the sickest person in Maryland who got assigned to Absolute Care, which is one of these new enhanced primary care companies. He was the most expensive patient in Maryland, multiple visits each month to the ER, multiple chronic conditions, double-digit medications. And so he comes to this company, and the first thing they do is hold a huddle with everybody that touches the patient. And the most important person in that huddle was the van driver who said, this guy's happy when I drop him off at church, and he's even happier when I pick him up. And so they decided to make him a greeter in the facility, and problem solved. He took all his medications. He was isolated and depressed. That went away because he loved the greeting and so on. And that type of innovation occurred because a private company that was getting a certain amount per member per month for this guy, or a certain amount per month to cover this guy, had an incentive to keep him healthy and out of the system. And I'm just not convinced, particularly since we've had 60 plus years of Medicare right now, that Medicare overnight can change from the type of payer that, pays for transactions to one that pays for health and prevention.
Got it. Thank you, Dave. That is the end of round one. Now on to round two. And this time, Dave, you get to go first. And this segment is about how Medicare for All affects costs. Dave, what's the connection between Medicare for All and costs?
Well, we've already established fee-for-service as the root cause of all healthcare evil. So the combination of fee-for-service payment and variation in physician prescribing behaviors have created an artificial marketplace for healthcare service provision. For example, the best predictor of cardiac procedures in any given market is not demographic, lifestyle, or environmental factors. Surprisingly, it is the number of cardiologists in that market. They literally create their own demand. This is what economists like Gerry describe as supply driven demand. And this is not the way normal markets work. In normal markets, there's an intrinsic level of demand that moves up or down depending on price elasticity. Supply adjusts to these demand pricing dynamics. In healthcare's artificial supply driven market, it distorts and fragments delivery. It explains, for example, why per capita Medicare costs in Miami are twice as high as they are in Seattle. Seattle's Medicare population isn't twice as sick as Miami's. Seattle even has a higher cost of living. So, what explains this? Here's the answer. Miami's doctors prescribe twice as much healthcare as Seattle's doctors. There's more healthcare, not better health. The right way to think about costs is in two parts: cost per unit and number of units. Medicare can do a decent job on unit costs, although revenue cycle shenanigans, like we've discussed, do push costs higher than they otherwise would be. But Medicare fails miserably on the number of units component. Like the Miami Seattle example illustrates, Medicare pays for an enormous amount of unnecessary care. Medicare also fails to pay for vital primary care, preventative, behavioral health, chronic disease management, and health promotion services. More units of these services would actually reduce healthcare costs by lowering hospital admissions and acute treatments. Single payer healthcare does not address this number of units problem. According to Choosing Wisely, Canada, which has a single payer health system, has as much unnecessary care as the United States. In effect, Medicare for All would grant access to Medicare's fee-for-service medicine to all Americans. It would lower unit costs, which is a good thing, but it would fail to control under and overutilization of treatment, which is, of course, a bad thing. As such, American healthcare costs would continue to be far too high relative to where they should be, while Medicare for All would improve access to healthcare services as currently delivered. It would do little to address America's declining health status, excessive end-of-life care, and inadequate care coordination. For that reason, Medicare for All is a huge boost to status quo healthcare delivery with its fragmentation, high costs, and poor outcomes. That's even before the massive healthcare industrial complex gets its fingers in the pie. Is that the kind of healthcare reform we want in the United States of America?
Good question. Thank you, Dave. Gerry, now you tell us how Medicare for All will affect healthcare costs.
Oh, thank you. Thank you. Again, David and I agree on a great deal, but there are important differences. So you're looking at why are healthcare costs high? Yes, cost per unit and number of units. But to quote a classic article, it's the prices. Most of the excess spending in the United States is not in utilization. In fact, we don't go to the doctor on average as much as anywhere near the average for the OECD. Across the board, only MRIs, CAT scans, and cesarean sections are more common in the United States than elsewhere, all of which, by the way, are usually done in the for-profit sector. So why are prices so high in the United States? The cost of inputs, yeah, but most of it is that more inputs are needed because of the inefficiency of our healthcare system. And most of all, because we allow for-profit companies to set prices even when they're positioned to exercise monopoly power. Factored together, price differentials in the United States versus elsewhere is due to inefficiency in administration and market power. Now, the irony about administration is that in both the United States, elsewhere, publicly and private, administrative costs are only about average. The difference is that our private share, which is much more expensive to administer, is much larger as a share of the whole healthcare sector. That accounts for an extra $400 billion in spending in the United States, about 10% of our total healthcare spending. As for monopoly pricing, Kenneth Arrow, my old teacher, emphasized monopoly pricing in his classic 1963 article on healthcare, widely cited but rarely read. Elite must-have hospital networks have been growing like mushrooms in the US, driving up costs. Network that includes Massachusetts General Hospital has bought our local hospital here. They have a quarter of the hospital beds in the Bay State, and they charged 10 years ago they were charging 4 to 5 times as much for the same services as other hospitals in Massachusetts. As they've spread, that's been driving up prices. By the way, to get to a point Dave made, the person who wrote that report, Martha Coakley, Attorney General,
Yeah,
ran twice for statewide office and got beaten both times. A Democrat losing in Massachusetts, overwhelmed by money coming out of Mass General, etc., for her opponent. Okay. Rand found hospital prices charged private health insurers were over twice as high as Medicare rates. It's not that Medicare can't control prices. It does. Yes, there are problems with utilization, but not with Medicare. Is the only system that's able to control prices. That alone would be a huge improvement. As for the pricing of prescription drugs and medical devices, I don't even need to say anything. Okay, thank you.
All right. Thank you, Gerry. Dave, any rebuttal to Gerry's comments on costs?
Well, again, Gerry and I are going to agree on some of the underlying economics here. I essentially wrote my second book, The Customer Revolution in Healthcare, because I was perplexed by the fact that healthcare wasn't incrementally improving, that we've been on this 50-year journey of ever higher prices without seeing improvement in health outcomes. And I decided that the underlying problem was what Eisenhower identified in his farewell address as the military industrial complex applied to healthcare. We have a massive healthcare industrial complex. Healthcare spends almost 4 times as much as the next highest industry on lobbying at the federal level. And that doesn't even include the massive lobbying at state level. So the result of that is a remarkably lax regulatory system in which we allow for monopoly and monopsony pricing power in local healthcare markets, like Mass General in Massachusetts, just as Gerry described. In Chicago, it would be monopsony. Blue Cross Blue Shield has 70% of the commercial insurance market here, and they basically set the prices because everybody needs them. So the combination of hundreds, if not thousands, of these micro markets where there's monopoly and monopsony pricing power undercuts the ability for level field competition, which we know is the way that competitive markets drive value. So when I think about the forces required to get to a marketplace where routine care can be priced as routine or commodity products would be in any market, it requires really getting at this healthcare industrial complex in a big way. So I guess I come to the same conclusion as Gerry as to the problem, but I am less confident that the government can overcome that healthcare industrial complex than the marketplace can if we give the marketplace a chance to innovate and figure out ways to deliver healthcare better, faster, cheaper, smarter.
Got it. Thank you, Dave. Gerry, any rebuttal to Dave's comments on cost?
Oh, absolutely. The medical industrial complex. Getting past it to get Medicare for all would take several miracles. And then to get the Medicare for all system to work properly, as David's identifying, to focus on the chronic care needs, to focus on coordination, would also be very difficult. But given the first miracle that we enact Medicare for all, here we would have a system that would, first of all, minimize administrative costs, and second, would provide the opportunity, the possibility of getting the types of changes that we need in the number of units of healthcare that David identified. For example, as I brought up before, it would get the incentives right. The National Medicare for All system would have an incentive to save money through improved primary care, improved behavioral care, etc. Second, it would allow the system to coordinate care across different providers. Just to bring up one common problem, the failure of electronic medical records. My wife sees a doctor, a specialist at Bay State periodically, but our primary care doctors are owned by Mass General. They can't talk to each other electronically. To exchange information, they have to print out the electronic medical records, and fax it. Who else uses a fax machine but doctors' offices? And this is why. So we can't even get electronic medical records to work properly in the current for-profit fragmented insurance environment. So the only possibility to do the right things would be through a Medicare for All system.
Got it. Thank you, Gerry. That is the end of round 2. Now, on to round 3, and the topic is the quality of patient care. Gerry, you get to go first this time. Tell us how Medicare for All affects the quality of patient care.
Thank you. Yes. Well, of course, the first thing about quality is access. If you don't have access, you can't have quality. So that's the first way Medicare for All would matter. But second is behind every doctor in America, every physician, every practitioner in America is an insurance company reviewing his or her decisions and telling him or her how to practice medicine. Who's making these decisions? Rarely is it a trained physician. They come into the picture only during appeals. No, it's a partly trained college graduate at best, reviewing a stack of files according to some rubric devised by people looking to restrict access to increase profits. The incentives are wrong, and the people making these decisions are wrong. To quote a friend of mine, that snot nose in Omaha doesn't know my patients. And every review leading to a denial of care saves money, even if it's overturned on appeal, because the insurance company profits from the float and profits from discouraging doctors from going ahead with particular procedures. Why do we have such a focus on acute care? Because acute care is harder to deny. It's the dealing with behavioral health. It's dealing with effective long-term preventive care that's easy for the insurance companies to get away with denying. And when you deny these, you save the float, you discourage doctors from doing it, and you encourage needy patients to leave. When my father was selling coffee in New York City, and he tried to have a better product at a lower cost. He was very successful at this. He and my brother made the company the biggest coffee service in New York. This is where free market capitalism works. Better coffee at a lower cost. But that's not the way health insurance works. People buy insurance because they usually don't incur gigantic medical expenses. So they buy insurance for those rare times when it happens. And in the language of the insurance industry, it's the medical losses that drive profits. Medical losses, paying for care. You want to find the people who are going to cause you those losses and make them go away. Lemon dropping. And you want to find healthy people like my daughter's 20s, 30s, and attract them, cherry picking. Now, you can try, as the Affordable Care Act does, to prevent this type of behavior by insurance companies, but then you've got more administration because you're trying to fit square peg into the round peg of social insurance. It doesn't work. If we want a system that will be like social insurance, we should get social insurance through Medicare for All. Thank you.
Great. Thank you, Gerry. Now, Dave, you tell us how Medicare for All affects the quality of patient care.
Sure. The right way to think about quality is through a simple 2x2 matrix with bad and good medicine on the x-axis and bad and good market behaviors on the y-axis. So the lower left quadrant combines bad medicine and bad market behaviors. This is a dark place. It's riddled with fragmentation, overtreatment, undertreatment, high prices, and poor quality. The upper left quadrant is good medicine, but bad market behavior. Here, overpricing reigns. An individual may need an MRI, but has to pay $5,000 to receive it. Medicare for All with governmental price controls can mitigate but not entirely eliminate overpayment. Along with universal health insurance coverage, these are Medicare for All's principal attributes. In the lower right quadrant, bad medicine combines with good market behavior, overtreatment reigns. An individual doesn't need the MRI, but only pays $500 for it. Any unnecessary care diminishes quality. Medicare for All would do almost nothing as currently configured to address the overtreatment. Indeed, current payment formularies encourage it. This is what logically happens when providers optimize reimbursement payments, not health outcomes. Quality and value suffer. The upper right quadrant is where good medicine and good market behaviors converge to deliver the right care at the right time, in the right place, at the right price. We have pockets of this type of convergent healthcare in the United States, but they are the rare exception. Kaiser Permanente is an example of a vertically integrated health company that emphasizes prevention, health promotion, and better outcomes. Their business model emphasizes these services because they are financially at risk for their members' health. That's essentially the key to better healthcare in the country, in my opinion. Unfortunately, the other three quadrants, fragmentation, overpayment, and overtreatment, dominate American healthcare. Failure to address the perverse economic incentives underlying this dismal reality will perpetuate the existence of America's suboptimal care delivery. America's artificial, supply-driven healthcare marketplace has created significant distortions in the industry's resource allocation. As a consequence, healthcare in America is asset-heavy, customer-unfriendly, error-prone, and resistant to change. The vast majority of healthcare services are routine. Providers have standardized protocols for treating patients who present with routine conditions. This makes healthcare a mature industry from a services perspective. Most mature service industries decentralize to get closer to customers, like Gerry's coffee shop, reduce costs, and increase customer convenience. While some decentralization is occurring in healthcare, the industry is still highly dependent, like the Mass General Hospital example, on centralized high-cost delivery models. As Deming, Drucker, and other management gurus have repeatedly demonstrated, eliminating waste and the costs associated with it are the keys to improving quality. Medicare for All reinforces wasteful status quo behaviors that diminish quality, increase medical errors, and frustrate providers and patients alike. More fee-for-service medicine will improve access without improving quality. That is the unfortunate truth about Medicare for All.
Thank you, Dave. Gerry, any rebuttal to Dave's remarks?
Oh, yes, yes. Kaiser Permanente is a great example. It has been a very successful model. And Medicare for All would replicate one aspect of it, having the incentives right for the insurer. You're responsible for the people, you're going to be responsible for their care over time, so you have an incentive to have good primary care and preventive care. The other aspect of Kaiser Permanente, and one of my favorite cousins was a Kaiser doctor for decades, is a great degree of decentralized control, exactly what Dave brought up with Drucker and Deming. Doctors would meet and they would be, as a collective, the group of doctors at a clinic would be making vital decisions. We need to not only do we need to get the incentives right and the financing right to provide access, but yes, we need to get the doctors back in charge. And there's no way that can happen with for-profit private insurance. For-profit private insurance does not have an incentive to provide good medicine. On the contrary, as I said, bad medicine can raise your profits by driving people and doctors away. If we want good medicine, we have to have it through a public agency, financed through a public agency. We have to do away with for-profit insurance. And we also need to empower doctors on the ground and rely on their professionalism rather than their for-profit incentives. If all we do is give the doctors, turn every medical practice into a little insurance company, with accountable care or other financial arrangements like that, then it will just make more private insurance. We need to do better than that by empowering the doctors as professionals with, of course, some supervision from the top, and then all that gets into very important details. But the basic parameters are clear: decentralized medicine by people concerned with the health of their patients, and national health insurance through Medicare for all.
Thank you, Gerry. Dave, any rebuttal to Gerry's remarks?
Well, I'm glad we're spending a little time on Kaiser Permanente because they're the example of a vertically integrated company that has both insurance and medical provision as under the umbrella. Therefore, since they get paid, their revenue coming in is fixed, they have an incentive to deliver the right care at the right time in the right way at the right price. My biggest disappointment in healthcare in the United States is that the buyers of healthcare services, governments and self-insured employers, haven't demanded more value from the system. In fact, when you look at self-insured employers, their rates of increase in terms of the cost of health insurance have gone up at double the rate of medical inflation, which in and of itself is double the rate of regular inflation. So the insurance or the provider network is increasingly counting on subsidies from self-paid employers, which is unfortunate. So why aren't they demanding more value? And I think the answer gets back to the monopolies and monopsony positions that we see in local marketplaces. They simply aren't strong enough to let their purchasing dollars determine good purchases. So Gerry spent a lot of time talking about insurance companies. I've spent a lot of time talking about the evils of fee-for-service medicine. The insurance corollary to fee-for-service medicine is what's called ASO, Associated Service Organization, which is basically where insurance companies get paid to administer claims on behalf of self-insured employers. And these companies like to take 15% off the top for a function that should probably cost 1 or 2%. And they want to keep doing that forever. So the answer isn't in keeping the insurance industry the way it is or keeping the provider industry the way it is. The answer is in companies like Kaiser Permanente that combine these functions. And so you get vertically integrated insurance and provision and the right economic incentives to deliver the right care in the right way. So I think we agree on that. Where we disagree is whether the government is better positioned to do that or the private market. One of the really unfortunate aspects of Medicare for All is that it would do away with Medicare Advantage and exchanges, which are, I believe, some of the more effective engines for innovation in healthcare now as public-private partnerships that truly are transferring risk to the companies and then making them accountable for the health and health outcomes of their members.
Got it. Thank you, Dave. And that is the end of round 3. Now it's time for closing statements. Gerry, again, as our guest, you get to go first. What are your final thoughts on Medicare for All?
Oh, well, thank you. Yeah. My final thought is a comparison between the United States and Canada. Since 1970, kind of 1971, we passed the first HMO law in the United States on the federal level, and Canada finished the establishments of Medicare in Canada. I swear they call it Medicare just to make fun of us because their Medicare covers everybody. But since 1971, virtually all of the increase in US healthcare spending is due to inflation. A little bit because of the aging of the population, but that's it. No increase in utilization. It's all inflation because healthcare prices have risen at an annual rate almost 2 percentage points above the general inflation rate. So then look north to Canada or look at our Medicare system. No healthcare inflation above the cost of living. So all of the increase in healthcare spending in Canada, after taking account of the aging of the population and population growth, is because of increased utilization. If we had adopted a Canadian style system in 1971 and maintained that rate of healthcare inflation, we would be saving today almost $1 trillion. Resources that could be used to increase utilization or devoted to some other purpose rather than processing bills to maintain an inefficient and wasteful healthcare system. Now, I've been talking about these issues about healthcare because that's our topic, but we got to keep in mind it's not only healthcare; it's the whole economy that we're talking about. Healthy people are more productive. If you look across the OECD, countries that have a healthier population also have greater labor productivity. We would be increasing our national income by probably trillions of dollars if we had a healthier population and if our entrepreneurs were free to start businesses instead of having to worry about health insurance, and if our business leaders were free to concentrate on their core function rather than having to deal with health insurance. So there's more to this than just the 18% of our GDP that's spent on healthcare. There's also the future of our whole economy. Thank you.
Great. Thank you, Gerry. Dave, you're up. What are your final thoughts on Medicare for All?
In the aftermath of World War II, there was a vigorous debate whether a government managed market socialist economy could allocate resources more effectively than a capitalist economy. And given the circumstances at the time, it was an entirely appropriate debate to have. Europe was in ruins. Memories of the Great Depression were still fresh. In many respects, communism and fascism were responses to unbridled capitalism. As history has shown, though, top-down market socialism hasn't been an effective economic model for managing an economy. A market socialist system requires an army of technocrats to understand market dynamics, set prices, allocate resources, establish priorities, and police black market behaviors. Given the complexity of these combined tasks, it's really easy to make mistakes, end up with too many tin pans and not enough tin cups, too many surgery centers, not enough primary care clinics. Capitalism overcomes this complexity through buy-sell signals that shape competitive dynamics from the bottom up. They push high-functioning markets toward equilibrium. In essence, the Medicare for All debate is a reprise of this post-World War II debate. This time it's about the appropriate role of government in healthcare provision. So while capitalism has emerged as a superior economic model, it comes with a significant caveat. Governments have installed social safety nets to protect their citizens from disruptions that capitalism causes. Access to universal health insurance coverage is a hallmark of an advanced economy. The US's unwillingness to date to provide universal health insurance coverage is a major policy failure. Granting universal health insurance coverage, however, does not and should not require top-down management of the US healthcare system. Government does have valid roles to play in supporting a high-functioning healthcare economy as a buyer of healthcare services, as a regulator of public safety, as a guarantor of level field competition, as a force to address market failures. Our current system is the worst of all worlds. Government uses complex formularies to set payments. The commercial market replicates them. Private companies ruthlessly exploit those payment formularies. A passive legal and regulatory environment encourages system manipulation and even fraud. Medicare for All treats some symptoms of the US healthcare system's dysfunction, but it does not address the system's massive structural defects. Only the private sector working in partnership with an enlightened government can redistribute healthcare resources effectively, promote innovation, and deliver real healthcare value to the American people.
Great. Thank you, Dave. Now, as the impartial moderator, I won't declare a winner in this first ever 4sight Health Virtual Health Policy debate. I will declare that you both did a great job arguing for your positions, and you gave us a lot to think about as we head into the final 6 months of the year and into 2022. And as you listen to the timer, you guys pretty much stuck to the rules. So you did a great job there too. So my sincere thanks to both of you. And that wraps up our debate. If you'd like to learn more about the topics we discussed, please visit our website at 4sighthealth.com. Thanks for watching. I'm Dave Burda for 4sight Health.